Over the last 3.5 or 4 years, we've concentrated our data gathering and analysis on the Medicaid program for the reason that I've just explained, but specifically we've targeted the 3 main programs within Medicaid that provide home and community-based services. And just for the purposes of record here, I've outlined those 3 programs here, and in the parentheses, I've indicated what our main data source or main data sources have been for collecting information on those. And these are fully explained within our publications and on the website. But just to note here, the 3 programs that we've been looking at have been the state plan optional benefit, the home and community-based waivers that Mike Oxford alluded to, and the mandatory home health programme. And on this slide, there are details there which suggest or underline the fact that these programmes are not substitutes for each other. There are fundamentally and significant differences between these programmes in terms of who they cover and what services are allowed and what kind of cost caps states can employ on these programmes. And I guess one of the key differences between the 3 programmes is the fact that all states have to provide the home health benefit, but the personal care state plan, optional benefit and waivers are optional programs. Although all states do provide waivers, apart from Arizona, but only 32 states have chosen to use the personal care option to deliver home and community-based services. So here we come to some of the evidence or the data that I was talking about, and this slide kind of presents some good news, but it's moderated good news. The top line on this graph shows that between 1999 and 2003, the percentage of all long-term care beneficiaries or recipients of Medicaid that receive home and community-based services increased from 50 to 57%. So that's good news. So of all the people that get long-term care through Medicaid, now 57% get them through home and community-based services as opposed to institutional care. Also good news is the fact that between 1997 and 2005, of all long-term care expenditures through Medicaid, now 36% of it is spent on home and community-based care as opposed to institutional care, and that has increased since 1997 from 24%. So that's kind of good news in a way, but it still means that fully 67% of all Medicaid long-term care is spent on institutional care. And this is what is referred to as the institutional bias within Medicaid. And this is what attempts at expanding home and community-based care are attempting to kind of remedy or rectify this institutional bias, which still means that fully 67% of all long-term care expenditures under Medicaid provide institutional care, despite all of the consumer-driven efforts to remedy this, despite Olmsted and despite all of the federal and state initiatives to address this. Fully 67% of all Medicaid expenditures still go on institutional care and not home and community-based care. Beneath those kind of global figures within the Medicaid program, there has been significant variation between the development of the 3 programs that we've been looking at. Yes, all have increased in terms of participation over our study period, but the rate of increase has varied significantly between the different programs. And in terms of participants, which we're looking at on the 3 programs, the program that has grown fastest has been the Medicaid waiver program. Now, we haven't specifically conducted a study to explain that, but it seems reasonable to expect that if you go back to the previous slide, which showed the differences between the programs, the Medicaid waiver program has got built-in cost controls, and it seems to be that states prefer to expand the provision of home and community-based care through the waiver program because it has got built-in cost controls. They can cap the number of participants and cap the expenditures. And maybe it is that states prefer to expand their provision through waivers rather than chancing their arm perhaps more through the development of the personal care program, where they might be exposed to greater risk of expanding enrolment. So that's the varying, this slide shows variations in the development of the 3 Medicaid programs. This shows the similar variation in the expenditures on the 3 programs. And unsurprisingly, and despite the cost controls, it shows that the waiver program has grown in terms of expenditures at a far higher rate than the other 2 programs. This is not necessarily saying that the waiver program has grown individual waiver programs have grown exponentially or out of control, what this probably reflects better is the fact that more states have implemented new waiver programs and covered more people. This doesn't mean that the cost of the waiver program is spiraling out of control and going through the roof. It just means that states are possibly covering more people through more waivers. In a similar way to the fact that we showed that there was the institutionalised bias within the Medicaid programme towards institutional care, here we have a similar kind of flip when you look at the participants served on the 3 different programmes. So while the vast majority, if you like, of people are covered under the waiver programme, it also shows the highest expenditures as well. Those were national figures. One of the key findings that our studies have shown is that beyond these growth in expenditures and participants across the 3 Medicaid programs, there is huge interstate variation in terms of expenditures and participants on these Medicaid programs. And this just shows an illustration of that by showing the 3 highest states in terms of participants on Medicaid HCBS programs and the 3 lowest when judged against the US average. And just a note that Texas looks very good by this metric. It covers an awful lot of its folks under Medicaid home and community-based services. But when you look at expenditures per participant, Texas is nowhere to be seen. So it covers a lot of people, but it doesn't spend much on them, is the bottom line. And that kind of message comes across on a number of states, and I shouldn't really highlight Texas here, but it's just to illustrate that the states that do well in terms of coverage don't necessarily do as well in terms of expenditures. But the underlying point is there's huge and significant variation between states in terms of their spending and participants in terms of Medicaid HCBS. Part of the reason for that might be due to the policies that states use to govern their programs. And here is a kind of busy slide, but it attempts to summarise some of the findings from our survey of all states about what cost caps and what types of cost control measures states use on their HCBS programs. And of particular interest to people like Mike Oxford, I'll draw your attention to the consumer direction line. And this is a rather crude way of getting at the issue of consumer direction, which I know is a hot topic, but we asked states to indicate whether or not they allowed people to hire and fire within their programs. And there's a huge variation here between the 3 programs that we've looked at, with 63% of the personal care programs, which operate in only 32 states, reporting that they allowed some element of consumer direction, whereas only 20% of home healthcare programs and only 44% of waiver programs allow consumer direction in 2004. This is a complicated slide. And basically what it attempts to portray is a rigorous statistical analysis of the explanators of why some states spend more and cover more people on Medicaid HCBS than others. And we conducted 2 analyses. We controlled in our analysis for all the usual factors like the number of people on Medicaid, the amount of need within the state and what have you. And we were attempting to find out what factors differentiate states in terms of their expenditure on Medicaid, HCBS and their participant. And I would draw your attention, since I'm running out of time, to the second finding on the participation analysis, which shows that if there's a change, the 2 columns in this diagram, in this table, show that what the standard deviation of the measures is, and then the estimated effect is it's a statistical way of showing that hypothesizing a change by 1 standard deviation, what effect that would have on what we're interested in. So on the second analysis, we're interested in participation in a state on Medicaid home and community-based programs. And that second line shows that if you can change the voting record of your US senators by 1 standard deviation on the measure, you can increase participation on state Medicaid programs by 66%. Other factors on this slide aren't immediately changeable by you and me in this room. That factor we have some influence over, and our friends and colleagues and neighbours have some influence on that.